do that. So, all right, should be recording now. All right, today we have one of our own. Ha Dang is a senior statistician in the Children's Oncology Group and an assistant professor within our division here. And today she's going to talk about an experience in modifying the hybrid design for a phase 3 hematopoietic cell transplant trial at COG. All right, thank you.
Thank you. Okay, so since you all probably know me already, so I'm not gonna introduce myself again. So I hope my talk today will be helpful or informative for you, because it is one of my favorite trials thus far, and so I thought it's good to share the experience. And this is a roadmap of my talk. So this study right now is approved by NCI CTEP, but we are still corresponding with them about some element of the analysis plan and the design in general. So so it's not activated, or it's not actually registered with clinicaltrials.gov yet. So I would consider everything here is confidential information. So I will share with you things that I think that is shareable right now. But feel free to ask me for details if you want for context. So I'll share with you some study background, the initial design that we proposed, and then our interaction with NCI and essentially CTEP, which is the division who reviews many of the COG trials, and then why we landed to at the hybrid design, and what we had to do to adapt that particular design to meet the needs of our transplant trial. And then I will go over how I calculate the sample size, and there are other miscellaneous, I would consider them as miscellaneous items that NCI throw at us that we would also have to address. Okay. This study has been in the works since 2018. We want to conduct a trial that will shift practice in the bone marrow transplant community. And not just shift practice, but we want to shift practice quickly. And so for this reason, we propose an initial design as a randomized superiority trial design. So we'll enroll patients under 21 years old. They are diagnosed with AML and ALL. They are required to be in complete remission before they could receive a transplant. It's going to be an open label trial because they will know what type of donor they receive when we randomize them. The primary endpoint is the composite GRFS, which stands for graft versus host disease relapse progression-free survival. And we will measure this outcome by 1 year post-transplant date. And so we choose this particular outcome. It's a composite outcome. And we chose this because this is the outcome that has been widely used in the BMT community. So this is the initial meetings that I have with the study team to understand the study, the outcome, and what they want. Along with that, there are also some issues that we identify from the beginning, in that there will be a lead time between randomization and the day the patient actually going to receive BMT transplant, because both the patient and the donor have to go through workup tests. They have to go through the testing to make sure that they are ready and suppress immune system to make sure that could get ready for them to receive the transplant. So that could take anywhere from 8 to 12 weeks, and we really cannot get both donor because we compare two donor choice. So we really cannot get both donor to do workup tests. So that we could move the day of enrollment and randomization near the days of transplant that in like drug therapy trials, because that would be unethical, and it also costs money, and centers would not want to do that. And so from the get-go, we know that patients will randomize to either donor choice A or B, and from that, then they and the donor will have a gap of about 8 to 12 weeks before they actually receive the procedure. So then the other issue is that there are risk factors that we cannot confirm at the time of randomization, because, for example, complete remission and minimum residual disease. These are risk factors that associate with the outcome, relapse, death, and GVHD. So for complete remissions risk factor, at the time of randomization, we will not be able to know what the patient, whether they're going to be in complete remission or not. But the surgeon or the doctor who treat them will make a guess, and that guess is not going to change. So, for example, if that patient, if the doctor is saying that, oh, this patient will be in complete remission 1, then either they're going to be in complete remission 1, or they are not reached complete remission. And if they don't have complete remission at the time of transplant, then they are not eligible for transplant, and they will be considered invaluable for the primary outcome analysis. For minimal residual disease, the doctor cannot predict this at the time of randomization. We know it by the time they go into transplant. So by the transplant day, we will know it, but we don't know it at the time of randomization. So we decided that for this, we were just going to adjust for MRD at the end of the study, so in the final analysis. So with that, we, after like a lot of listing and discussions, and the fact that we know COG leadership is only enthusiastic about a superiority claim, we finalized our design as a superiority trial with a composite outcome. And the sample size is around 210 patients, one-on-one randomization. And so we thought that this is a feasible size for a pediatric transplant trial. Then we could complete this enrollment in about 3 to 5 years. And then when we submit the proposal to the COG Scientific Council reviewers, I think most of the comment come back was relatively positive. They did ask us to refine a few things, but nothing major. Like they didn't ask us to like totally change the design or anything like that, or totally change the outcome. The one suggestion that they asked us to do is to consider a modified intention to treat analysis because of this issue when we have a gap between a randomization and the day of BMT, and then patient may phone up for a reason that not relate to the donor choice at all. And so we feel that that is reasonable, that we would be able to do just a modified intention to treat analysis and excluding the kid who drop off before they actually receive BMT. So after we got approval from COG, we sent our proposal to NCI and CTAP for their review. So the first round review, they asked us, why do you want to prove that arm A is superior to arm B? We know that arm A already have some non-clinical benefits, like it's shorter wait time for the donor, and it's actually cheaper than arm B. So they, in their mind, they said that as long as the clinical outcomes are comparable, then arm A option as a treatment is acceptable. Why do you have to prove it's a superior? And so for this, we our response was that we agree that arm A has is this lower cost, it's much shorter time to wait to have the procedure to be done. But a successful trial that proving arm A is superior to arm B would make it a practice changing, and that in that this practice changing will be more dramatic and faster and happen faster than just saying that, oh, I'm AE equivalent. And so with that response, they were okay. But the second comment about the choice of the outcome is something that drives this hybrid design eventually. So they say that the day of transplant and the day of randomization have a gap, and that patient may experience an event, not GVHD, but relapse, death, and that kind of counting toward your outcome. So if they drop out of the trial because they die, for example, then the population who actually receive BMT will be different between the two arms, considering that patient in arm B may have to wait a longer time to find donor or to get the donor ready as well. So their question, it was more like a question. They asked, is there a reason why you don't consider a co-primary outcomes for this particular trial? Could you consider GVHD separately from DFS? So since it's a question, so we feel like we could push back and keep, a composite outcome. And then we explained to them like that GVHD is expected to be superior for arm A compared to arm B, but DFS it just marginally benefits. We don't expect it to be like really big gap difference between the two arms. And so if we're going to design a trial that have co-primary outcome, the sample size required to achieve a certain power for DFS would be really big, in the like 500, and that will make the study infeasible to enroll patient in a timely duration time, because we aim for like 3 to 5 years. So, and so then we submit our response to them. In the second review, they say, this is a phase 3 trial, and you want it to be a practice-changing trial. Then you have to use intention to treat analysis. And the clock has to start randomization, and that is what they want. So there's no question, there's no debate. This is what they want us to do. So they have a lot of issue with using a composite endpoint, GRFS, to claim superiority, because they say GVHD is a short-term outcome. And here is a severe GVHD. DFS is a long-term outcome. So they don't agree to combine them. And they want us now do a co-primary outcomes trial. In that the DFS outcome will be you're going to do an intention to treat analysis for DFS outcome, and you start the clock from randomization date. For GVHD outcome, it's going to be a modified intention to treat analysis, and you start from the date of BMT, or the day of transplant, because patient is only at risk of GVHD if they receive it, a transplant. So that is essentially what they asked us to do. So we come back again in a call with them. We reiterate the issues of feasibility, considering superiority test of both outcomes. And that lead us to the hybrid design, were proposed by Fretlin and others, statistician, I believe as NCS. So a traditional non-inferiority design, we set we kind of switch the null and the alternative. It's like in the swap it with like a superiority trial. So the null is that it is inferior, and the alternative is that it is not inferior. So when we consider a hybrid design, instead of setting it to a hazard ratio of 1 under the alternative hypothesis, we set it to a number that's slightly less than 1. And we can only use this design when we expect a marginal benefit. So for us, for our trial, DFS is, we know it's going to be non-inferior, but we also think that it's going to be a little bit better, but not by much. And therefore, doing a regular superiority trial would have like almost like a 500-ish patient. And if a traditional non-inferiority design would require even more sample size than that. So I asked the PI, and she has all along been saying like, it's only expected to have a marginal benefit. So I know that even before I read this design paper, that's what the PI have told me. So it was not hard to ask her to give me some references to support this statement before I go and do this design for them. The advantage of this design, the hybrid design, is that you can just use the conventional test statistic for any non-inferiority design. It's actually gonna decrease the sample size compared to the traditional non-inferiority because obviously the gap between 1.5 and 1 is smaller than the gap between 1.5 and 3. So you also don't need to do multiple adjustments for the type 1 or multiple testing adjustment for type 1 error rate because the way that we're going to do this hybrid design is we could go with a sequential testing of the hypothesis of non-inferiority and superiority. So step number 1, you will test against the inferiority null hypothesis. And if this test fails, then you will conclude that arm A failed to demonstrate non-inferiority, and then you're done with the trial. Oh, you're done with that, right? If it passed this initial test, then you go to step 2, where you test again non-superiority. If it passes, then you conclude arm A is superior. If it doesn't pass this step, then you would say, well, arm A is non-inferior without superiority. And this is just within like one outcome. So you think of proving overall survival or event-free survival, that one particular outcome will go into a sequential test like this. And you don't have to do any multiple testing adjustment or anything like that. The question here is, could you do the opposite? Could you test superiority first? And then if it fails, then you test for non-inferiority. The answer I think is you could, but it has to be a plan. It has to be pre-planned in that setting that you would do it. But the problem is, we know sample size required for non-inferiority is always larger than sample size required for superiority trial. So you may not have enough power to do that. There's another issue where that Franklin et al. Mentioned in their original paper is that when we do analysis for a non-inferiority trial, obviously, phase 3 trial, the gold standard is intention to treat analysis. But for a superiority trial, that intention to treat analysis will give us a conservative result. So the analysis, the result tends toward the null hypothesis of no treatment effect. But for a non-inferiority trial, that no treatment effect is actually our alternative hypothesis of non-inferiority. So when we do intention to treat analysis for a non-inferiority trial, you may not be conservative as you think. So in a non-inferiority trial, we would have more weight on a per protocol analysis or like a more modified intention to treat analysis. just because of that. So, so obviously, if we conduct a trial, a non-inferiority trial, and the analysis, the result from an intention to treat analysis doesn't agree with the result from a modified intention to treat analysis, then it could be problematic. And performing just a modified intention to treat analysis alone doesn't guarantee unbiased. That's just something that I know from the literature that I read. Okay, so for my particular trial, there are some considerations that I have to think of. First of all, it is a co-primary outcome, so we have to consider GVHD and DFS separately. DFS is our competing events with respect to GVHD, and they also correlate to some extent, meaning that patient who develops severe GVHD is more likely to die later on, but less likely to have a relapse. That is per the PI of the trial. So it's a little complicated, but the objective is still that we want to demonstrate arm A is superior to arm B. So we set the rule for the study conclusion is that arm A is superior if DFS is non-inferior and GVHD is superior. Arm A is non-inferior if DFS is non-inferior and GVHD is not superior, given that GVHD is not substantially worse than arm B. And arm A is inferior, now it's the inferior part. If DFS is inferior, then that alone will make it inferior treatment. Or if DFS is non-inferior and GVHD is substantially worse. Okay, so that is the conclusion that we want to make for our study. And then aside from that, we also want to include a non-binding futilities boundary. So in setting up this design, we always take a look at how this would affect the type 1 error rates and how that will play with the power and the sample size. And the study committee is very sensitive to the sample size because they don't want anything too high. Hovering about 300 patients or less would be acceptable to them. Otherwise, it would be infeasible, and they would not even consider going forward with this trial at all. I read up the literature, and Berger have shown that an alpha level test of the null rejects if and only if all tests of component hypotheses rejected at level alpha. And so this play well with a trial when you have two outcomes and the alternative hypothesis is an and statement. And we don't really need to do any multiple testing adjustment. So for my particular trial, the overall hypothesis I set is that under the alternative hypothesis, DFS is non-inferior and GVC is superior. So this and statement gives me a leeway of not adjusting for the type 1 error rate. And the null is that DFS is inferior or GVC is not superior. And then the component hypothesis is this setting. So DFS will have the inferiorities hypothesis of hazard ratio of around 1.5 versus an alternative of non-inferiority or marginal benefit, I would say, as around hazard ratio of 0.8. And for GVC, we have a regular just a superiority setup hypothesis. And these numbers are consulted with the PI of the trial. It's not something that we just randomly select. And in terms of testing, it's also a sequential test, so that we would have not mess around with adjusting for the type 1 error rate. So first, I will test for the inferiority null hypothesis, and then if that is rejected, then I will go on and test for the GVHD to see if it is superior or not. And so here's a little short, just a very short, quick proof of how the type 1 error rate is able to control for this particular setting and sequential test. each of them is bounded by level alpha. If that, alpha is your rejection region or type 1 error rate. And then the second test is only be done if we reject the null hypothesis of the first test. So essentially, it's just a union, A1 union with a section of A1. So essentially, it's just bounded by alpha. And then we don't need to adjust for multiple testing. So that is type 1 error rate. Now it's the sample size or the power. And it's not as straightforward in terms of like a closed form formula, I would say, because there's some correlation between GVC and DFS. And so because of that, I just gonna go using a simulation. So there's a package in Stata called Survival Sim package that could handle computing risk, multi-state illness and death scenario. You could also specify your own hazard functions as well. They have survival exponential, Y-ball, and user-specified survival distribution. For my simulation, then this is the design that I have. So type 1 error rate of a non-inferiority trial, one-sided type 1 error rate would be 0.1 with a power of 0.9. And the for superiority hypothesis for GVC, I'll set it as 0.05 one-sided type 1 error rate with a power of 0.8. And so this has been generally accepted as COG, and we feel that this is a trade-off we could use to achieve a feasible sample size. It's not, I don't know outside COG if this is okay to use, maybe not, but this has been accepted for a few trials COG, so that's what we go with. For the simulations, I do a very simple assumption, exponential survival distribution with a 12-month follow-up and proportional hazard assumption. And so now, so like I said, survival Siemens data could handle computing risk, but the computing risk that they have there mean that for example, a patient has GVC and then that's it. It doesn't go on and have like death or relapse and stuff like that. And so that is, I think that would be a little more conservative than assuming that some patient with a GVC will go on and have something. If I want to consider the scenario where a patient has GVC and could transition into a death event or relapse event, I will need this hazard rate, number 3, which the study team don't have for me, like in a concrete, reliable data type thing. So I did try to ask the disease chair, and he has a trial going right now, but he cannot share the data with me because it's an ongoing trial. And the GVHD event that they define for his trial is different with the way we define our GVHD. We define our GVHD as severe GVHD. I think he defined using a different grading or something like that. So, so he say, okay, I could give it to you, but it's not really applicable. And I'm like, oh, okay, all right. So hazard rate for someone who enter into the trial, they don't have any event yet. They go and they could have a GVHD. This hazard rate number 1, we have that data or the information to put in the simulation. Someone enrolled could just develop the DFS event straight. This sort of hazard ratio rate that we also have. We have good data for that. But to consider a multi-state unit death scenario, which is more realistic for our trial, we would need this hazard rate, and we don't have that. So, so for my particular trial, when I respond to NCI, I assume that we don't have this at all. So patient either have GVHD or they have DFS. I did not have this, and I acknowledge that in the statistical section. And the reason is that if somebody eventually have DFS, if you have more events, then you have more power. So it's just a conservative for now. But for the purpose of this presentation, then I think I asked the PI, the disease chair, and he kind of gave me, but like I tell you, he said it may not be applicable. So he showed me the plot, and he said, well, about 75% DFS by 6 months post GVHD diagnosis for the kids who have GVHD. So then, with this information, if I want to simulate this scenario, multi-illness, multi-state illness death scenario, I would need another layer of assumption, which is what is the non-inferiority margin and what is the marginal benefit for this group of kids who are transitioning into the DFS once they have GVHD. So this is my setup. So 75% versus 65%. And marginal benefit would be around 75% versus 80%. Okay, so here is the simulation and the power from that simulation. So each two rows are a simulation set. I've done about 5,000 replicates. So without considering the fact that GVHD could transitioning into death, I would need 300 patients to attain about close to 90% power for just the non-inferiority design for DFS. But with the proof of superiority for GVHD, I could attain roughly 85% power. If I could consider multi-state unit death scenario where GVHD patient could transition into death and or DFS outcome, I would have more power, obviously, around 96, 97% power for DFS alone, and around 90 or 91% power to claim arm A is superior. Essentially, if I do a multi-state model or simulation, I only need probably 250 patients instead of 300. But since the data is not really reliable to me, so I don't feel comfortable to put forward this proposal. So essentially, I just showed computing risk scenario with 300 patients, and it's still within the feasibility sample size range that they are okay with. This slide assesses the type 1 error rate for 300 patients, roughly around 10%, like we say, like I said it, at one-sided 0.1 for type 1 error rate, to conclude that this is like the type 1 error rate would be for DFS. Right? So if we aim for 10%, this is around that. With more patients in a multi-state simulation, you're still hovering around 10%. So it's not like a raise or it's going to inflate type 1 error rate too much. So we send that to MCI. They're okay with that. So now is the other miscellaneous stat comment that I have. But it's like I want to yank my hands out when I try to deal with these, because to them they say the first comment is that the study should be shut down if we observing more than 30% non-compliant or inevaluability rate post randomization. And so we get together with the third team get together. We ask why 30%? Where is that number come from? Is there any kind of like a scientific reason behind this number? We don't know. So we're trying to understand that, and so I reached out to the statistician at NCI to ask about this, and he said that this comment purely about the feasibility of the intervention more than anything. In that if a donor choice is not available for the patient, then it just not make sense to even conduct a trial. So that is just that. There's no statistical thinking behind it or anything like that, just a feasibility of this intervention. So we have to come back and do a little more convincing with him, talking with him one-on-one, and explaining to him that in reality, patients may cancel a transplant because they're not qualified to receive a transplant, because they're not in complete remission, or they have infection before transplant. And so any of these patient characteristics have nothing to do with donor choice, and if they think of feasibility. And we estimate in real life, these cancellations or delay could be up to 30%. If they really concerned about feasibility in terms of whether that donor choice is available for the patient to even do it, the transplant, that is donor unwilling and unavailable. That is about 10% or less in real practice. So as of right now, we raise this number to 40%. What they ask is 30, but we, in our response, we say, taking into account these, and we give them a longer explanation of what is actually happening in real practice, of how the patient actually treated and get ready for transplant. We ask for 40% to shut down the trial or to modify the study. And then we say that we're going to also delay randomization as close as possible to the day of transplant to minimize dropout. We will also regularly monitor for delays and cancellations, and then we put in a plan near 40%. I believe like around 30% to no, not this number, but around 30% of patients enroll. And then we're going to check this rate of delays and cancellation and see how we are relatively to a 40% of cancellation rate. And if it's so close to this number, then we need to kind of pause the trial and amend the study in some way to make it a feasible trial. But with regard to it's a non-inferiority trial, and you have high dropout before the patient actually even take it. High dropout post-randomization, essentially. We said that we're going to present both analyses, the intention to treat analysis and a modified intention to treat analysis. And if they are concur, then we're going to do okay. But if they contradict each other in terms of the result, then we're going to have to explore the reason why our results are not the same. So that's we will wait how they will respond to us, because we just resubmit our response last week. So we'll wait to see what they respond. The other comment is more interesting, and a few of us at COG are a little puzzled by this. So they said, chemical incident approach may lead to bias if the treatment have unequal effect on the competing event. So they asked us to use a log rank test where we will censor the other outcomes, like death or relapse, when we analyze GVC outcome. And then they gave us this reference, which is the two citationists and CI, who the author of this paper. So if I have more time, I will go over that paper a little bit, because it's interesting, but I don't really think I agree with the paper too much. But we were in a short time range to do a lot of digging and time crunching. My statistical class in clinical trial teach me when you have competing risk, you use grade test. And that was my simulation I did. I use grade test to do all of those power analysis, type 1 error checking, and stuff like that. So when they give us this comment, I have to go back and change it to essentially a cost-specific hazard log rank test. So that redo on that analysis again. So we say, all right, fine. If this is what you want, we're going to do a primary analysis using the cost-specific hazard log rank test, the test GVHD analysis. And but to estimate the cumulative incidence, a point estimate for GVHD, we're going to use competing risk. And in the exploratory analyses section, we specify we're going to also perform the grade test for GVHD. So that is sort of like a compromise that we want to put in, just so they know that we do what they want and we also do what we want. So in conclusion, of my experience in designing this transplant trial, we are able to modify the hybrid design to get a feasible sample size and still able to do a superiority claim, let's say. And we are able to show that type 1 error is controlled. And by simulation, we get everything set up, and we submit all of that characteristic to the NCI for them to review, and essentially they approve the design. So what I also learned from this whole experience is that this multi-state transitions options available in this survival sim packages data. That is more realistic, but we would have to have data to feed into that simulation. The feasibility of donor choice in a phase 2 trial, that comment, bit surprise to us. But our learning lesson from that is that we could have provided a more lengthier explanations about what is actually going on in real practice, how a leukemia patient is diagnosed and treated, and during that time frame, the doctor would already start to, initiate the process of selecting donor and stuff like that. And this whole education about how transplant and donor choice actually is and what are the rates in real life could have been helpful as a background for the statisticians at NCI. And then this thing about modified intention to treat versus modified intent to treat in a non-inferiority trial is also interesting. I never thought of that before, but now I kind of know now. Okay. The cause-specific hazard log-rank test versus grade test is an interesting comment from NCI. And I think maybe I could have like a few minutes to go to that paper just to show my understanding and my thought of it. Let me see. So here is the table from that particular paper where Franklin and Korn show that when you have competing risks, let's say lambda 2 is a competing risk for my trial would be like DFS, and lambda 1 is GVHD. So they say that if you run a grade test, you use grade test, you will have inflated type 1 error. Whereas if you use a cause-specific hazard log-rank test, essentially you censor the competing events and use the log-rank test, you maintain the type 1 error, right? But this paper doesn't really tell me how they arrive at the 200 sample size, whether they calculate it so that they get this 80% power using a two-sided 0.05, using this log-rank test to arrive at here, and then they use that sample size to do a grade test. They didn't really specify, but I think that's what it is. So my understanding is, if I simulate my trial and I fix this to be 0.05 as a type 1 error rate, this should be even lower. Although we typically try to match, right? Like whatever you test is used to power, to estimate the power, that test should also be used to analyze your primary aim. But if we kind of don't do that like this, right, the way it's shown here, if I set this to be 0.05 and I calculate my sample size that way, this would be less than 0.05 because that's just my part of it. So I'm not sure why he would be concerned about me using grade tests, and I simulate using grade tests. But yeah, so that is something that I feel a little bit interesting. Perhaps I will reach out to the statistician at NCI and ask him more about this paper as well as the comment. But that's it for my presentation. If you have any questions, please let me know.
Thank you very much. Do we have any questions within the room? I see Jim on there, but then any questions online as well? Thank you. I was going to ask you a question, but I think you sort of maybe showed a little bit of the details, but about the unequal competing risks or competing events and how that could lead to bias. You know, I'm just wondering, within your simulation framework, you could do the same sort of thing, but I think you'll probably get the same results that you had, that you just showed on sort of that figure. And it'll be dependent upon the correlation between the two factor or the two sort of arms of the two outcomes. Yeah, it's interesting to see how that would fit within your framework as well, because it's a slightly different than what I presume what they're showing in those simulation, because you're doing a superiority type of test, so it might be a little bit different.
Yeah, because that particular paper, it's more of, I'm only interested in, let's say, GVHD, and I don't care about DFS at all. So when we test it, then if you disregard the result from DFS, perhaps it would kind of give you a bias. But for my design, I consider result from both outcomes. It's a co-primary outcome. So I don't think it would be an issue. So I think when he put a comment about a bias in the treatment effect, he meant the issue with power. But then if that's the case, I power using great tests. So I would think that if I power using great tests, and then if I even use that cost versus hazard log rank test, then I would have even more power, or even more conservative in type 1 error. The only, I guess the only benefit I see from that paper is that, okay, so if that's the case, then you could reduce your sample size a little bit, because you clearly use great test, you clearly have more power. So if you use cost as a hazard log rank test, you could reduce your sample size a little bit. But yeah, I think I may want to reach out to the statistician at NCI and see if my understanding is correct about his paper.
Thank you. Any other questions from those in the audience or online?
I had a question about the DFS versus mortality.
Yep.
Is there a difference in mortality, because of treatment severity between the two arms?
So the question is if there is a difference in mortality between the two arms?
Treatment-related mortality.
Treatment-related mortality between the two arms?
Yeah.
Well, we believe that one arm is non-inferior than the other with a marginal benefit. So that is our hypothesis. So inferior by a certain margin, like usually, like for example, if we think arm B have a DFS of 75%, then what we believe, based on literature review, is that arm A would be around like 65 in terms of non-inferiority, and the marginal benefit from what we see could be a range of like maybe 5% more than 70%.
Yeah, I mean, what I was getting at is that the question about whether DFS is really the right measure to use, or whether it should be just mortality.
I couldn't really hear the question really well.
I I wanted to know whether DFS is actually disease-free survival, DFS, whether that is really the right endpoint as opposed to just overall mortality.
Oh, okay. So you say, should we have considered overall survival rather than disease-free survival?
Yeah.
Well, that's a good point. The NCI, when they respond to us, they did suggest, you guys could consider overall survival or disease-free survival. So the study committee eventually picked disease-free survival.
Okay, trying to look and see in the audience there if any other questions. If not, thank you very much for speaking with us today.
Thank you
And
for the
we'll
opportunity.
Yep, we'll see everybody next week. All right. Bye, everybody.